All right. Hi, everybody. We are so glad to have you here tonight. We are coming to you with a topic that is very important to the VCP disease community. And this is actually a presentation and a webinar that we put together in response to the A New Hope program, the program for young adults that was hosted last year. There was a great need expressed for wanting more information about family planning in VCP disease. And so this webinar is coming as a result of that program, and we're happy to be speaking with you tonight. So by way of introduction, I'm familiar with many of you, but for those of you who I haven't met, my name is Ashley Thompson. I am a genetic counselor with experience in rare disease, and I've been working with Cure VCP disease for the past a little more than a year now. And I helped design and host the A New Hope program last year. And so today I've partnered with Kim Skellington, who is also a genetic counselor, but she's in the reproductive space. So she is going to lend her expertise here tonight, and we'll discuss the genetics, fertility, and reproductive options that might be applicable to you and your family. So on the agenda tonight, we'll give a brief overview of VCP disease and genetics, though I recognize this is probably not a crowd I really need to give an overview of VCP disease to. Next, we'll discuss how VCP disease is inherited, just to make sure everybody is on the same baseline. We'll also review some genetic testing considerations, family planning and reproductive options, and lastly, we'll leave plenty of time for questions and discussion. And so before we jump in, I just want to make sure to provide just this quick disclaimer is that this webinar is for educational purposes only, and the information shared with you tonight should not replace medical advice. And so Pam and I both encourage you to please discuss your personal medical or reproductive decisions with your healthcare team. And I also want to take the time to remind you that while we are genetic counselors and we have the opportunity to support you in your decision to participate in genetic testing, we by no means require or would force you to do so. We have the liberty of, also endorsing you in your decision to not pursue genetic testing. And so we are here as genetic counselors to support you in whatever decision you make. And I like to say, whatever decision is made between you and your family around a table with those that you love is never the wrong decision. So, whatever works for your family is what we will support. All right. So, like I said in the agenda items, I don't think I need to give this crowd an overview of what is VCP disease, but if you want to kind of just take a glance at the slide and remind yourself really that VCP disease is quite heterogeneous in its presentation, right? It presents very differently in from person to person and even within the same families. And so, as you all know, it can affect muscles, bones, and nervous system, right? But members of the same family may have very different experiences, which is one reason why family planning can be so complex. At baseline, family planning is complex, but then when you add VCP disease and those considerations along with it, and the variability of how VCP disease may look in your family, there's a lot to consider here. So we want to just arm you with information to inform you what your options can be in this setting. So just to get us all on the same baseline, like I mentioned, we'll just review some quick genetics concepts here. And so genes are the instructions that help our bodies function. It is kind of like a recipe book for life and everything that our bodies do. And our genes are contained in DNA that's tightly wound up in all of our cells, like you see on the left here. And so we have two copies of every gene, and we inherit one copy of each gene from each of our parents. So one from our mother and one from our father. And a variant or a mutation is a genetic change in a gene. And so I want to also, maybe change the narrative just a little bit or let you guys know that we all have different changes in our genes, different mutations, but not all mutations are known to cause disease. And these genetic changes that are different between me and my neighbor, these are what make us different, and it's normal and we expect to see them. It's just part of our genetic diversity. However, sometimes you can have a change in a gene or a portion of a gene that causes that gene or that protein then not to function, and that would result in disease. And so that's what happens in the case of VCP disease. You can have genetic changes or variants in the VCP gene that lead to VCP disease. And so you only need, right? I said we have two copies of every gene. And in order to have VCP disease, a person only needs one altered copy of the VCP gene. So a mutation in one copy of that gene. And so each child from an individual with VCP disease has a 50-50 chance to inherit or not inherit the variant. And this chance is the same in every pregnancy, and the outcome of one pregnancy does not affect the outcome of the next. If you're more of a visual person, this is what we would refer to as autosomal dominant inheritance when we require just one copy of that gene to be affected. And so you can see here in this picture on the left, you can see that the father has um, one affected copy of the VCP gene and one unaffected copy of the VCP gene. And so and the mother is unaffected completely, so she has two purple unaffected copies of the VCP gene. And so this father would have a 50-50 chance of passing on his affected copy to his offspring, and a 50-50 chance as well of passing that to the unaffected gene on as well. And so this is the same as if the mother were affected. It's still the same 50-50 chance. The sex of the individual does not influence the outcome there. It's always going to be a 50-50 chance if you are aware of your VCP mutation status. And if that's positive, it will always be a 50-50 chance to pass it on to sequential pregnancies or offspring. And this image, I will say, is also in our updated family guide to genetic testing, and that's available on the Cure VCP Disease website. And so, like we said, VCP disease can look different in different people, and that within the same family, symptoms may differ, the age of onset may differ, and the severity may differ. And so while genetic testing can help predict whether someone inherited the familial VCP variant, it cannot predict exactly when symptoms will begin, which symptoms someone will develop, and how severe those symptoms may become. And so for many families, this uncertainty can make family planning decisions especially difficult, like I mentioned at the beginning, when these decisions are already difficult to begin with. And so genetic testing for VCP disease, looks different for everybody. And like I said, we support the decision to test for VCP disease, but we also support the decision not to test for VCP disease. But some reasons that individuals may choose to participate in genetic testing for VCP disease include confirming a VCP disease diagnosis, identifying whether someone inherited a familial VCP variant. It can help inform medical care and family planning, which is what we'll be reviewing tonight. And that understanding inheritance of a VCP disease within a family can help individuals and families explore different paths to building and expanding their family. And so we're very fortunate to have Kim Skellington join us here tonight. And just one last time, I want to remind you that there's no universal right decision, only what feels right for each person and each family. And so with that, I'm very excited to introduce you to Kim Skellington, a reproductive genetic counselor, to discuss the reproductive and family planning options in the context of VCP disease. Take it away, Kim.
Thank you, Ashley. And that was very well said. I think that's the biggest message to really take away today is that when it comes to these reproductive options, there again is not one way to do this, and it's very personal and optional. The goal here today is just to let you know what's out there so that you can make a decision of what makes sense for your family. So we'll dive right into it. And I typically begin talking about just the basics of fertility. So these are things we've learned before, but just so that we're all on the same page. So when it comes to fertility, there are three components that we need to be thinking about. We have the egg, which in this picture, it's labeled number 1. Eggs are located inside ovaries. So that's going to be what's inside that black box. The next component we need is a uterus. So this is where a pregnancy grows and develops. And the last component, but also still very important, is the sperm. And so for each of these components, oftentimes if we're thinking about a couple, it may be where one member of the couple has both the egg and uterus and the other member may have the sperm. But there are times in which there might be an individual person for each of these components. And we'll talk more about what I mean by that in the later in the presentation. But for our fertilization, just to go over that briefly, so again, we're looking at a picture of a uterus and an ovary. The ovary is the pink oval, and inside of it are the eggs. And furthermore, the eggs are inside of something called follicles, and that's what's represented in the yellow there. And for a typical menstrual cycle, one of the main goals is that there's going to be ovulation, which means one of those eggs are released by the follicle into the fallopian tube. The fallopian tube is what connects the ovary to the uterus. So you'll see this yellow arrow. This is to illustrate the journey of the egg outside of the ovary into the fallopian tube. The next step is inside of that blue box, which is really the magic of where the egg gets fertilized by the sperm. And then once the egg is fertilized by the sperm, I'll refer to it as an embryo. And what it'll do is continue its journey down the fallopian tube and hopefully implant into the uterus. So that briefly is how fertilization works. But if you heard, there are a lot of steps involved. And this really is a very complicated process. And in every step that I mentioned, there needs to be fine tuning and timing that's really important. So it's not as easy as maybe you heard back in class in high school in sexual education. It really can be a complicated process and can take a while for individuals to spontaneously conceive. So I always want to highlight that it is a process that involves a lot of interplay when it comes to hormones for both the person with ovaries and the person with the sperm, as well as structural concerns or things that can arise and timing of everything. So an egg inside of a fallopian tube will survive for about 24 hours. So if the goal is to fertilize that egg, the sperm needs to be there to fertilize the egg. So a lot of things need to happen to make this go correctly. And while today we're focusing on genetics, the other thing I also like to highlight in these conversations is the fact that environment plays a role too in our fertility. Unfortunately, this is a conversation that's happening a little bit more frequently in society. Recently, you guys maybe have come across this documentary already, but on Netflix, they have the plastic detox, which I think does a really good job of highlighting that there are things we're exposed to in our foods or how our foods are served to us that actually disrupt the hormones that are really important for our fertility. So I think that's a great way to learn a little bit more. There are articles out there that look at things like how alcohol impacts our menstrual cycles and also ways to optimize our natural fertility. So I just wanted to highlight those options to take a further look. The one thing I usually pull out, particularly from this Optimizing Natural Fertility Committee opinion, is folic acid supplementation. So if anyone is planning to have a pregnancy in the future, it's really helpful to have prenatal vitamins being taken prior to actually conceiving, particularly the folic acid that's in those prenatal vitamins. It is shown that folic acid supplementation can decrease the chance to having a baby with a particular birth defect, commonly referred to as spina bifida. It's not to eliminate this chance, but it is to hopefully reduce that chance. I always want to mention that in conversations when it comes to thinking about conceiving. The last point I'll mention before we dive into the family planning aspect is the reality of age. So a person with eggs will be born with all of their eggs, so they age alongside with them. And so studies have shown time and time again that egg quality is going to be impacted as someone ages because there are biological mechanisms that age too. And the next thing that's impacted is the number of eggs that someone has. So each menstrual cycle, there's going to be a reduction in the number of eggs. So this isn't to say that there's an optimal time to necessarily have children or think about it. What this is really trying to say is that there is a reality of age that needs to be integrated in the conversation, just letting people know that this is something that has been shown as a variable when it comes to fertility. With that being said, we'll dive into those family planning options that are out there. And the way that I've constructed the rest of the conversation is really based around who is being tested. So we'll talk about testing of individuals related to the fertility space. Then we'll talk about testing of a pregnancy. Then we'll dive into testing of embryos. Testing of individuals. So you guys may already be very familiar with this concept. Maybe you've personally already had genetic testing, but this is going to be when if someone has certain symptoms, they may be tested for a panel of different genes. Maybe they would go under something called whole exome sequencing. In cases when there are familial conditions, maybe testing specifically for the familial variant. But lastly, what's pertinent to the fertility space is a test called carrier screening. Carrier screening is intended to see if an individual is a carrier of a genetic condition. And the whole idea is if both members of a couple are identified as carriers, or maybe one individual is a carrier of an X-linked condition, then they may have the chance to have a child with that genetic condition. So the intention of this screen is to essentially identify those families where there's an increased chance to have a child with a genetic condition. And for carrier screening, they are evaluating hundreds of genetic conditions through this test alone. Now, what's different with these conditions is that they are not autosomal dominant like VCP disease. Instead, they are either autosomal recessive or X-linked. Briefly, autosomal recessive means that, again, we all have two copies of every single gene. One comes from mom, one comes from dad. Someone with an autosomal recessive condition or someone who is a carrier, this means one copy of their gene has a variant that's pathogenic or a mutation, but because they have the other copy that is typical and it's working in the way it's expected to, they typically don't have symptoms of the condition they are a carrier of. So a lot of us don't even know that we're carriers until we do this genetic test. If it's been identified that both members of the couple are carriers of the same genetic condition, there would be a 25% chance to have a child with that condition. And then if it's an X-linked condition, there's a similar chance, like autosomal dominant, in that there's a 50% chance that that could be passed on. Why would someone want to know this information? Well, as we'll go over, it gives the opportunity to test embryos for that specific condition that they've been identified as carriers of, as well as the option to test pregnancies or babies after birth. Although this is absolutely an optional test. Sometimes people feel like, okay, there's already one condition that I'm already thinking about. I don't need to add more conditions to worry about and choose not to pursue this testing. Other people feel like, you know what, I want to know about all possible things. So they may decide to pursue this genetic test. So again, completely optional and very personal decision. Next, we'll talk about testing of a pregnancy. So there are two different ways that this can be done, or two different types of genetic testing options. The first type is called screening. So screening is intended to let someone know if a condition may be increased or decreased for that pregnancy. So screening is not meant to diagnose. Kind of like if you think about going to the airport, you're putting your luggage through the x-ray machine, and the intention of this is to screen pieces of luggage to identify those that may be at a higher chance of having something prohibited in them. And if so, then the TSA officer actually rummages through that person's luggage to really see if that's the case or not. So similarly, screening in pregnancy has the same concept where it's trying to identify those pregnancies that are at a higher chance of actually having the genetic condition, but it cannot diagnose for the genetic condition, so additional testing would be needed. In addition, screening is not able to evaluate for all genetic conditions. For example, VCP disease is not commonly a screening test available during pregnancy. So these are other genetic conditions that are an option to have done. And these are usually done through blood draws. Now, pertinent to this group and pertinent in terms of diagnostic testing, so that's the other type of genetic test available during pregnancy. These are ones where you're able to test for specific conditions of interest. So if a couple were identified as carriers of a genetic condition, diagnostic testing would be an option for VCP disease, as well as other genetic conditions as well, like chromosomal conditions like Down syndrome. In order to do a diagnostic test, there does need to be a procedure performed. A procedure is where a sample from the pregnancy is being obtained. And in the United States, there are two different types of procedures that are often performed or offered. So in the first trimester, there is the option of something called the chorionic villi sampling or CVS procedure. This is where a doctor is trying to get a placental biopsy from the pregnancy. That placental biopsy is then sent to a genetic testing lab, and whatever genetic tests that are being requested can be run on that placental biopsy and the cells that come from the placenta. There's also the option of a different procedure called the amniocentesis. This is done in the second trimester. This is where the doctor is trying to get some of the fluid that a baby is in. So, a baby is in something called amniotic fluid. In that fluid are cells that come from the baby directly. And so, the doctor is trying to get some of that fluid in order to isolate those cells or the DNA from the baby to be able to send those off to a genetic testing lab and again be able to run the requested genetic tests. As you might be thinking as I'm describing these procedures, there are some risks in doing them because there is a needle that enters into the pregnancy, whether that's through that placental biopsy or through trying to get the amniotic fluid. And those risks look like things like infection, bleeding, or miscarriage. That's why this is very much an optional test in order to, given that there are some risks associated to it. Some people feel like while there are risks, the information is really important to them to be able to make decisions. Other people feel like, you know what, maybe the risks aren't worth it at this point in time. Unique to VCP disease, and in this situation, it would be the consideration that this may be determined as an adult onset condition. And typically, just like in the pediatric population, adult onset conditions are not usually performed on children. The same concept applies in the prenatal period as well. This doesn't necessarily mean it may not be an option to pursue VCP testing if you'd like to for your pregnancy. It just may be something where you need to advocate a little bit more. There are times that people feel like I really need to know if my pregnancy has this condition because I may choose options like termination. Other times it's parental anxiety that's really coming into the picture. So that's all to say that while typically adult onset conditions are not evaluated during pregnancy for with these procedures, it's not to say it's off the table. It just again may require a little bit more of a conversation with your providers. All right, lastly, we'll talk about testing of an embryo. And so it says testing of pregnancy, but here we're referring to embryos. So there's just a little bit of a difference when we were converting our slides over. So, testing of embryos, this is always going to be with in vitro fertilization or IVF. And I'm going to talk a little bit more about what that is. The test's name is called pre-implantation genetic testing, so PGT for short. And this pre-implantation is referring to the embryo that is not yet implanted into the uterus. So, pre-implantation genetic testing. Currently, there are a lot of different types of PGT tests. These all evaluate different things for different reasons. So, for example, the first one, that aneuploidy, what this is referring to is chromosomal abnormalities. This isn't something that we'll dive into too much in today's presentation, but this essentially is looking to see if there's the correct amount of genetic information. So there are times that there's too much genetic information or not enough, and that's what this first test, this aneuploidy test, evaluates for. But more relevant to today's conversation is this third test called monogenic conditions. So this would be pre-implantation genetic testing for monogenic conditions. It's a mouthful. We can shorten this to PGT-M. And this monogenic word, so mono meaning one, genetic referring to genes, so one gene. So this would be conditions caused by one gene. And this is relevant for VCP disease as VCP is the gene causing this condition. So, how does this process all work? How do you pursue testing of an embryo? Well, the first step is IVF or in vitro fertilization. So I'll refer to it as IVF throughout the rest of the presentation. So again, I'm showing that picture I originally showed where you have that ovary and not quite the uterus, but that fallopian tube. And this is just to underscore again that typical menstrual cycle or process. So one egg is ovulating and actually going to be released from the follicle into the fallopian tube in order to hopefully be fertilized by the sperm. That's the typical process. And that's often referred to as spontaneous conception. IVF, however, the goal here is actually to get more than one egg cell out of the ovary. So, how is that done? Well, it's by hijacking the natural hormones in a person's body. These hormones include FSH and LH. So, the individual is giving more of those hormones in order to get more of those egg cells to mature. Then, those egg cells are retrieved directly from the ovary. So again, the goal of IVF, so in vitro fertilization, the fertilization part is to fertilize as many embryos as possible or to create as many embryos as possible. So that again is with an egg and a sperm to create that embryo. The in vitro part means outside of the body. So that's why I have those two pictures there to illustrate that all of this is not occurring in the fallopian tubes or uterus, but instead in these dishes. That's to the bottom right there. The first picture, though, is to illustrate that the sperm is actually going to be put inside of cups like this, and then a healthcare provider is going to obtain the sperm, put it inside of this dish where the egg is, in order to allow that sperm to fertilize the egg to then create an embryo. And the embryo is inside of these dishes, and there's some culture media or some liquid in there to help them grow, trying to simulate the same environment as a uterus. The PGT part of all of this, so once the egg is fertilized, it creates that embryo. And when the embryo is about 5 or 6 days old, it's often called a blastocyst, but we can still call it an embryo. Then it will be biopsied. This means a few of its cells are being taken and placed inside of a test tube. That test tube is what is being shipped to the laboratory, and embryos will stay at the clinic that they were created in. The embryo at this stage of its development has about 200 cells, so only about five are actually being extracted or biopsied and sent for the testing, which is a much smaller amount of cells than if someone had genetic testing themselves in their blood. So in your blood or in your saliva, there are hundreds of thousands of cells, whereas for PGT testing, they're really only working with about 5 cells. So it is an amazing technology that individuals have created here. All right, so we talked about how that all works, but and in terms of the process, but what about the actual genetic analysis? So this is the PGT-M part. So this is where the laboratory is actually running the analysis that's being requested. So PGT-M again is when there's a known familial variant. So it's a very specific test that's going to look specific for one variant, maybe two variants, depending on the family history. So it's very unique testing. And what someone will do if they are interested in this option of PGT-M testing of their embryos is that they will work with an IVF clinic, and they'll work with a doctor called a reproductive endocrinologist or REI. When they work with these providers, they will bring their own clinical notes about their family history of the condition as well as their genetic test results. What the clinic will then do is send that information to the laboratory that they work with, and at the laboratory, they do something called a case review. During these case reviews, there are two main objectives. The first is that they're making sure that it makes sense for this family to pursue PGT-M, which in the context of VCP disease certainly is not going to be an issue, and that will be a check mark for the lab's review. But there are other conditions out there where there may not be clear symptoms related to the genetic condition, so it may not make sense. The second thing they're doing is looking at technical feasibility. So can they actually create a test designed for this family? So PGT-M is unlike any other genetic testing out there in that the testing they are creating a test specific to someone's family's DNA profile. This is not off the shelf, so other genetic testing is off the shelf where anybody can have it done. But for PGT-M, it is very specific to the family's variant and other DNA points. So it's very unique testing. So the lab is actually creating a test for that family's DNA profile. And again, it's unlike anything else that's out there. So they have to make sure that they think they can actually create this test based on the information they receive from the clinic. Once the laboratory feels like, okay, this makes sense to pursue clinically, as well as we think we can make this test specific to this family's DNA profile, the next step is to have a genetic counseling consultation. So this is where you meet with a genetic counselor, and there are multiple goals for this session. It's to provide consent to doing this testing. It's to learn more about the test, its timeline, as well as what additional information may be needed in order to proceed. If someone consents and is interested in proceeding with PGT-M, one of the next steps is to send in DNA samples. So I mentioned that this test is specifically designed to the family's DNA profile. Well, how the lab learns about the family's DNA profile is by looking at their DNA directly. So they would need to send in their DNA samples, whether that's from their saliva or from their blood. And I also mentioned of all relevant family members. So something else unique to this test is that sometimes family members are involved in the test design process. So what might that look like? So if you have a couple who both are interested in pursuing PGT-M, both of their samples would be sent to the laboratory, and then ideally both sets of their parents' DNA samples would be sent into the laboratory as well. Now, this is not always an option. There may not be family members available to participate. Maybe they've passed away. Maybe there is some challenge with getting them to be involved in this. So there's a backup option where family members may not have to be involved, but it really is a backup. And ideally, if family members are able to be involved, that's the gold standard is to have them involved in testing. And how, again, how that looks is that they actually send in their DNA samples in order for the laboratory to design that test specific to the family's DNA profile. After that test has been designed, there's the process of the IVF, where those embryos are being created to then allow for testing of those embryos. Lastly, the individual can then decide which of those embryos they would like to transfer into the uterus and be able to potentially not transfer embryos that may actually have the genetic condition of interest. So what do these reports look like? This is an example from one of the labs on their website. So I wanted to run through this very quickly. So this is where really what to pay attention to is that sample ID column where it says 1, 2, 3, and 4. This is the samples that are sent in from the embryos. So again, embryos aren't sent into the laboratory. Excuse me, it's the samples or those 5 cells from each embryo. So this is indicating there are 4 samples in total, so meaning the person had 4 embryos in total. Then in the dark blue box, I've highlighted where it says HTT-related disorder PGT-M result. So this is looking at a different condition, so not relevant to today, but it's looking at the HTT gene. If someone wanted to do this for VCP disease, it would look like VCP-related disorder instead, and then it would say PGT-M results. So for this laboratory, they use the words unaffected, affected. May not be the best terminology, but this is just how this lab reports this information. Other laboratories may use different terminology. But for the purposes of this test result, they have the word unaffected, which means the embryo did not inherit the familial variant. Affected means the embryo did inherit the familial invariant. So there are 2 results that came back as unaffected, sample number 1 and 3, and 2 that came back as affected, sample 2 and 4. The other thing to highlight here is the next line, which is PGT-A results. So this is one of the other types of genetic tests that can be done on embryo samples. This is looking for aneuploidy, which what I referenced a little bit earlier. This is essentially making sure that there's the correct amount of genetic information. There are times that there's too much or too little genetic information. So this is looking to see if there's the typical amount. And you'll notice that sample number 1 is highlighted in light gray and it says the word euploid under PGT-A result. That's a good result. That means that there's a typical amount of DNA. So that's what's intended. But for the 3 other results, there are chromosome abnormalities or too much DNA that was identified, which is not the ideal result. So the point of me going through this is really to emphasize that 1 out of the 4 embryos actually received favorable results. Because it was only 1, oftentimes multiple IVF cycles are needed in order to get more than 1 embryo. Because unfortunately, even though the 1 embryo here has received good results or what's viewed as good results, even if it was transferred, it may not implant. And even if it implants, it could result as a miscarriage or a pregnancy loss. So just because someone has 1 embryo, it doesn't necessarily translate that they'll have 1 child. There are other factors involved in things that could happen. So a lot of times the doctors at IVF clinics, they'll recommend someone to have multiple embryos available per child that they intend to have. So if someone intends to have 2 children, they might be recommended to have at least 5 embryos available for transfer. The other unique aspect is that while these results say unaffected and affected, it is something where sometimes people feel like if they're not able to do another IVF cycle, that they may be open to transferring an embryo that's labeled as affected or that has the variant. And this would just require a little bit more conversation with healthcare providers to talk through what that may look like for the family. Another unique aspect to VCP disease is this concept of non-disclosure and exclusion testing. So this would be for folks who do not want to know their genetic status. And if they do not want to know the genetic status, but they would like to have embryos that they transfer that are not at risk of the condition, that may be an option for families. So how is it possible to do something like this? How can you not know your genetic status, but actually test your embryos to be able to find those that do not have the genetic condition? So the first option is this non-disclosure testing, which really isn't commonly done in the US, but this is where a laboratory would test the person that, again, doesn't want to know their genetic status, so they won't tell them their results, and then they would test their embryos. The reason why this is not commonly done is because of the risk of disclosing that information to the person. And so there's some liability issue there. So this is not commonly done in the United States. Rather, this exclusion testing is what's offered to folks in these situations. So how does exclusion testing work? In this picture, I'll orientate you to what's going on here. You have the green box that is shaded in. This is supposed to represent the father of this son. So this is a little snapshot of a pedigree. And underneath the father, there's those two dashes. That's to illustrate his two copies of his gene. Then on the other side, you have the blue circle that is not shaded in. This is to indicate the mother of this son. And again, she has two copies of her gene that are light blue, and she does not have the genetic condition. Then there is the son, and the son doesn't know his genetic status, but what we know from the principles of genetics is that he will have inherited one copy of the gene from his dad, which is shown here in the dark green, and one copy of the gene from his mom, which is shown in the light blue. So he has two copies of the gene, one from mom, one from dad. That's typical genetics. The thing here is, though, we don't know if the copy he inherited from his dad has the familial variant. We just don't know that information. But this individual, this son, he doesn't want to know, but he'd like to test his embryos and make sure that he's transferring embryos that do not have the genetic condition. What the laboratory will do is test those embryos, and for any embryo that inherits the green copy of the gene, essentially the copy from granddad, because the embryos are related to the son's dad as the grandparents. So any of those embryos with granddad's gene copy, they will be assumed to have the genetic condition. They don't know, but they're making that assumption. And then for any embryo that inherits the grandmother's copy of the gene, they will be assumed to be not affected or not impacted. So with exclusion testing, the caveat to it is that there might be embryos that are excluded when they really shouldn't be because they don't actually have the genetic condition. But because the knowledge isn't wanting to be known, there's that caveat when it comes to this testing. And it's based off of the lab. So this again is where the lab will need to review the case to make sure that they can accept it for this exclusion testing process. So this is something where if we think back to that workflow I had shown you, that second step is where they'll do that case review. Is this technically feasible? Is this something clinically relevant? So they'll look over the case when it comes to sending in that documentation. If someone is interested in this IVF PGT-M option, whether that's with knowing the genetic status ahead of time or through this exclusion testing option, it's important to know that this is time extensive. It can take many months in order to create embryos, and so it's something to really be prepared for. It could be even up to a year to get everything in place. The cost, it may not always be covered by insurance, and despite money, cost, time, and effort, there's no guarantee for success. So success would look like having a child. There's also the medication that a person will need, particularly the person who has the egg cells, and it's important to ask how that might impact someone's current health and current treatments. It may require multiple cycles of IVF. which could incur higher cost and more time. And as I mentioned, PGT-M is really unique in that it's a test designed specifically for that family's DNA profile. So it may need to have the involvement of other family members, which can be challenging for some folks if you're not used to having your family with your medical decisions and discussions. So that's something else to just prepare for as well. Couple more slides and things to talk about. So, in the context of IVF as well, are both donor and surrogacy options. So, for donor options, if someone has a genetic condition and let's say they don't want to pass that on to their children, they could have the option to pursue a donor. So, whether they are the person who is contributing the sperm or the egg, there are options for donor sperm and egg, as well as donor embryos. So, there are some families that have created too many embryos, and so they may donate those to other families. There are also options of surrogacy. So, a surrogate is an individual who carries the pregnancy. So, this is the person who has the uterus, and when we think about the three components of fertility. And there are different reasons someone may pursue a surrogate. This may be for social reasons. So, if there is a same sex couple of two genetic males, they would have the sperm component, but they're not going to have the uterus. So, they may have a surrogate in order to complete their family. There are also some health reasons. So, for some individuals who have uteruses or women, they may not have, it may be contraindicated for them to have a pregnancy. So, pregnancies are very difficult. They have a lot of impact to the woman's body. And so, it may be that they have some health reasons that their doctors really say, you know what, this is going to be too much strain on your body. And we'd actually recommend you consider a surrogate. It's important to work with IVF clinics with who are able to work with surrogates because they have legal protections in place to make sure that the baby that is born from a surrogate will actually go to the intended parents. So it is important to be thinking about some of those legal aspects when it comes to surrogacy, and there are groups and individuals to help with that. What we won't dive into in today's presentation, but is equally relevant, would be options like adoption, fostering, remaining child-free, proceeding with a pregnancy and not doing any genetic testing, and waiting until that child is older to make the decision themselves to have genetic testing done, if at any point. And lastly, our key takeaways. So, as Ashley indicated, VCP disease is inherited, and each child or pregnancy has a 50% chance of inheriting that familial variant. Symptoms and progression can wildly vary between people and their families. And then we definitely went over there are many different paths to family building, and there are some people who actually utilize multiple of these paths. So some people may do spontaneous conception without genetic testing and then also maybe adopt. There might be people who utilize IVF with PGT-M for one pregnancy, but then decide to spontaneously conceive for another. So a lot of people will mix these options as well. There's no one route to go. And that's what the last bullet point emphasizes. No right choice, only what feels right for you and your family. And here are some additional resources for you all. So on the website, there is this genetic resource as well as the family guide. And of course, the opportunity to email any questions. But at this point, we'll actually open the floor up for those questions.